If you keep getting the same infection over and over again, that's not a random exposure to the bug, that's a pattern. Maybe it's the same sinus infection 3 or 4 times a year. You take an antibiotic for it, it clears, but then it comes back again. Maybe it's urinary tract infections that come 3 or 4 times a year. That same pattern, you take an antibiotic, it clears, but then it comes back again. Maybe it's yeast infections that come back. Maybe it's bronchitis that comes back. The same pattern, just a different tissue in the body. You get an infection, you take an antibiotic, you treat it, it clears, but then it comes back, and the cycle repeats over and over again. Now, quite often, you're going to be told that you're just prone to those. In this video, we're going to offer you a different explanation. An explanation that doesn't start with the infection at all, an explanation on why the bug gets in the first place. So let's talk about recurrent infections. The standard explanation for why this happens is it's just a repeat exposure to the bug. The combination of the exposure to the bug itself leads to the infection. After we treat the infection, we try and decrease the exposure to the bug. Now, if the exposure to the bug explained the susceptibility to getting infections, then some people shouldn't be having more infections than others. We all have the same exposure in many cases in our lives. So the focus on exposure doesn't explain this pattern, this repeating pattern that we see. Otherwise, everyone with the same exposure would have the same infection problems, and we don't all have them. So imagine we have two women living in the same environment, the same air, the same food, the same exposures to everything in that environment. One woman may get the normal immune exposures we all get, a cold or a flu or a bug once or twice a year. She doesn't have the repeated problems with urinary tract, yeast infections, sinus infections, and so forth. Then we have another woman living in the same environment. She has the exact same exposures, the same diet, the same air she's breathing, the same environment, and yet she suffers terribly through the year. Multiple lung infections, bronchitis, sinus infections, or urinary tract infections, or yeast infections. Again, same exposure, completely different experiences from an immune system point of view. Well, in some of these cases, the exposure is not the real problem. It's just the straw that broke the camel's back. One reason that second woman may have the increased infection rate is her immune defenses to that exposure are weakened. She may have an inflamed, irritated, and deficient barrier against that pathogen. It creates an open door in her that the first lady doesn't have. So we're going to talk about that barrier next. Now, infections need two things to take place. First, we need the germ, the microbe, the bug that will cause the infection. Second, we need a surface for it to land on. Both of those things have to be present in order for an infection to take place. Now, when that surface is healthy and functioning well, it can repel a lot of these exposures to the bugs we get right here. Now, this barrier on the outside of our body is very obvious. It's our skin. It protects us from particulate and dirt and things that we get exposed to when we're out and about. But we have a skin on the inside of our body as well. I've spoken about this in many other videos. It's our internal skin. It's our mucous membranes. If you pried your mouth open and pried your bum open, all those tubes in between are open to the outside environment. You have to have a barrier inside just the same way as a barrier out here. If we have inflamed and irritated skin on the outside of our body, it's going to be more prone to getting infected. The same concept happens on the inside as well. Now, we refer to this internal barrier as our mucous membranes predominantly. It's any part of your body that has a slimy mucus film over it. When you run your tongue on the inside of your cheek, you feel that slimy thin mucus there. Well, that goes up into the sinuses, goes down the lungs, and it lines the digestive tract from the mouth of the rectum. It lines the urinary tract, it lines the vaginal tract. Those tissues have three main jobs. One is they have to let the right things in. In our digestive tract, we have to allow food and nutrition to get into our system. In the lungs, we have to allow oxygen to get into our system. So it's a gatekeeper to allow the right things in. It keeps the wrong things out. Bugs and bacteria and viruses and dirt and things that shouldn't get absorbed into our bloodstream in the digestive tract. And it constantly has to repair itself. The skin on the outside and the inside, it's constantly being damaged and challenged and irritated by different things. It has to have the ability to repair and regenerate those tissues to repel the next infection or invasion. Every sip of water you take, every bit of food you eat, those mucous membranes are interacting with the outside environment. So you can see where the irritation can happen. Now, if the food and the water in the air is clean, quite often we have no issue. But when irritants or allergens get into those substrates, that's when things can start to get irritated in the mucous membranes and we can start to have barrier issues. So let's talk about the things that irritate and weaken and thin that mucous barrier. Not all of these are foreign invaders or irritants that we eat, breathe, and drink. Some of them come from within ourselves. One of the more common components to this is aging, hormone decline at menopause and andropause. Estrogen, progesterone, testosterone are not just reproductive hormones or sex hormones. These hormones play a critical role in keeping what we call epithelial support. Epithelial tissue is another name for this mucous membrane. It's a tissue that regenerates itself. Well, these hormones play a critical role in maintaining the tight junctions between the cells, the barrier, so stuff can't get between them. They help keep these tissues moist and lubricated. They help stimulate repair processes in those tissues. So as we get older and these hormones fall, we have less of that reparative and protective ability from those hormones. So this is a natural thinning that happens as we get older. Imagine as we get older, we get wrinkles and dry skin and cracks in our skin. That's the effects of aging and this hormone decline on the skin on the outside. Well, those exact same changes happen on the inside as well. And these changes don't just happen in the vaginal tract in women at menopause. They happen in all those mucous membranes in both men and women. These hormones are also significant anti-inflammatory hormones. Most people don't think of them that way. So as we go through perimenopause and periandropause, and as these hormones fall, the ability to fight inflammation in our body lessens. So a lot of times these inflammations get worse. So in these barriers, it's a double whammy. These epithelial tissues start to weaken as we get older anyway through the drop in hormone production, but also the inflammatory processes that can aggravate those tissues worsens because those hormones are less able to suppress the inflammation because their levels are lower. I have a separate video just on this menopause, andropause hormone impacts with respect to inflammation. There'll be a link in the video description below. It's called Menopause Isn't the Cause, It's Inflammation. This applies to both men and women. It's not just for women. These sex hormones fall in both of us, and the impacts on these tissues happen in both of us as well. Now, an important key point I want to make here is that we can't control our aging. There's no diet or vitamin or supplement or natural health practitioner that can make you 27 when you're 47. So we can't control our age. The other factors we can control, and one of the most significant impacting factors on these mucous membranes can be our diets. If you've seen any of the other videos on this channel, you're going to recognize this concept very easily. Now, as we talked about, age is one of the things we can't control, but there are other factors that we can control with respect to this epithelial and mucous membrane health. So what other things are damaging it? Well, what this video is all about, the occasional infection can do that. The once or twice a year cold or flu, or the occasional random infection or exposure. Those infections take root on this epithelial tissue, and when they take root, they inflame it. If that happens repeatedly, that can cause more serious damage in that tissue. Injury or trauma, unforced trauma, accidents, but also surgeries and things like that. Imagine someone having a bowel resection done, a biopsy in their lung, or any surgical intervention in any of those tissues can actually stress and damage that mucous membrane as well. Medication side effects, and this is a known entity. Anyone who's ever been told to be careful using NSAID drugs, non-steroidal anti-inflammatory drugs, because they can be hard on the stomach and the bowel lining. Those medications are known to cause damage to the tight junctions in these mucosal barriers. The cells can start to unzip and we start to get little cracks form in the middle. Now, one of the least talked about factors impacting this are inflammatory food reactions. And it's kind of illogical if you think about it. If we have an issue or an inflammation between the mouth and the rectum, logic and common sense kind of says it's likely going to be something that you're putting in the mouth that could irritate that. Or if you have an issue in the lung, it's got to be something that's going in when you're breathing that can irritate that. And as we've talked about in other videos with the constipation video, the reflux video, the IBS video, there's known and well-documented impacts of food issues on these mucous membranes. Now, something to keep in mind, these other factors here, you would think they might have nothing to do with food, but quite often they can have something to do with food. Medication side effects. If we have headaches, if we have chronic pain in a muscle or joint, what do we take for that? We are told to take these NSAID medications, these anti-inflammatory medications. Well, quite often these anti-inflammatory medications are given because of inflammatory reactions that we may be having to foods. There's known correlations between certain food sensitivities and allergies with muscle and joint pain. So if we eat a food, it can cause pain in the joint. It can also cause an irritation in the digestive tract lining. Well, the medication we take for the inflamed joint can also come back and cause inflammation in the digestive tract lining. That can also happen with injury and trauma. Imagine someone with bad celiac disease or inflammatory bowel disease like Crohn's or colitis. Celiac disease is a known food-associated inflammatory bowel condition. So if someone has a severe inflammatory bowel issue and they have to have a bowel resection done, that surgical incision through the bowel will go and weaken that barrier even further. Now, if food led to a condition that damaged the mucous lining and the epithelial barrier to the point where they had to have surgical intervention, the surgical intervention can go and damage that mucous epithelial barrier. Again, another negative feedback loop. The inflammatory food reactions can have a much broader impact than we typically think of with respect to how our internal skin can get damaged and irritated and lead to a weakened barrier. Now, we touched on this in the previous slide, how food can impact this epithelial barrier that we have. This isn't a theoretical concept. If we talk about what are called delayed hypersensitivity reactions, we're going to differentiate between immediate and delayed shortly. But an example of a delayed hypersensitivity reaction could be celiac disease. Someone eats gluten, they're allergic to it. The protein gets into the bloodstream and an immune response is produced against the gluten molecule. Well, celiac patients will have a tissue protein in the bowel that looks like gluten. So the immune antibody response that was created from eating the gluten will go and attack the protein in the bowel that looks like gluten. Well, this inflammatory damage in the bowel can lead to barrier damage that we've been talking about. Another example would be what we call immediate hypersensitivity reactions. These are reactions to foods that happen as soon as you eat them. Imagine a child who eats a peanut and they have a peanut allergy, or someone eats a scallop and they get nauseous and they throw up. Well, those reactions are caused by a compound called histamine released in those tissues. And there's research to show that histamine can have an impact on the barrier function and the barrier integrity. So we can have delayed reactions cause inflammatory damage to that bowel lining or the mucous barrier lining, the epithelial lining, but we can also have immediate hypersensitivity reactions cause the same type of damage to that barrier. Now, a really simple analogy I use with patients in clinic is a sandpaper analogy. Imagine if you went out into the yard and got a handful of dirt, you placed it on your arm, you left it there for 6 to 12 hours, and then you go have a shower and wash it off. Your arm is going to be fine. There's not going to be any issues with that. But imagine then if you took a piece of sandpaper once or twice a day and just scuffed across your skin like that. Now, the first few times you do it, it may not cause a major problem. But if you keep doing that repeatedly over and over again, that tissue is going to be very susceptible to getting infection. So if I take sandpaper and rub my arm for 2 hours, and then I go put dirt on it and leave it there for 12 hours, there's a really good chance that could get inflamed, irritated, and possibly infected. So the sandpaper analogy, this is what can happen with inflammatory food reactions in the mucous membranes, especially the digestive tract. We eat a food repeatedly. We have this little sandpaper scuff analogy that I mentioned before. It can start to irritate this epithelial lining right here. The tissue can start to lose moisture. It can start to dry. The cells can start to separate. And this can lead to that open door to infection. Again, we said we have to have a microbe and a tissue for it to land on. Well, if that tissue has an open sore in it, that microbe's going to have a much easier time taking root and colonizing versus if that tissue was intact. So when we eat these foods repeatedly over and over again, it's that little scuffy sandpaper reaction. We can see what that would do to us internally. So we're going to touch a little bit on these inflammatory food reactions. Now, when people hear the term food intolerance, food allergy, food sensitivity, quite often they're used synonymously. They don't really know the technical differences. It's the technical differences in these terms which make or break whether people get these issues figured out. A food intolerance is a non-inflammatory food reaction. A good example is lactose intolerance. Lactose is milk sugar. Someone eats or drinks something with lactose in it. It should be absorbed in the small intestine when they drink that. Most sugars are absorbed in right below the stomach in the small intestine. Well, lactose intolerant people don't have enough lactase to chop up and absorb the lactose. So that lactose goes to the colon undigested. The colon's a trash compactor filled with yeast and bacteria. What does yeast and bacteria do to sugar in a warm environment? It ferments. The bowel fills up very quickly with gas and fluid to the point where it can't fill up anymore. The bowel will cramp and spasm, and they have loose stool and diarrhea. Now, the important thing when I described that whole process, I never said the word immune system or inflammation once. They ate a food, they didn't absorb it here, it went to the colon, it fermented, and they had to poop out the fermentation byproduct. Food intolerances are non-inflammatory food reactions. They're restricted to the digestive tract because the food doesn't get absorbed. They typically always cause loose stool, cramps, gas, and diarrhea. They come on very, very quickly, and they get out of your system as soon as you poop that food out. Those are food intolerances. Now, food allergies are called immediate hypersensitivity reactions. Immediate is the critical word here. A kid eats a peanut, their throat swells up really, really quickly. Someone eats a scallop, and they get nauseous and throw up fairly quickly within an hour or two. These reactions come and go very quickly, so quite often we can figure them out. Not always, but quite often. This is what is perceived as the typical food allergy out there in the conventional medical world. When allergy testing is done, it's typically for this type of allergy. But there's another type of inflammatory food reaction that most people have never heard of. These are called delayed hypersensitivity reactions, and delayed is the critical word here. We're going to talk about that more in a little bit. Now, the difference between these types of food reactions is the core of everything I do with my patients from an inflammatory food point of view. In the description below, there's a free guide that you can download that explains how these reactions differ, the technical differences between them, and it explains very clearly why these reactions can be so hard for people to figure out. We're going to touch on a little bit of it right here, though. The two types of inflammatory food reactions. Now, food allergies, these are called immediate hypersensitivity reactions. The classic example is the anaphylactic reaction. They come and go very quickly. They're associated with an antibody called immunoglobulin E or antibody E. Immunoglobulin is a big fancy word that means antibody. These are the antibodies that release histamine. Histamine, most people have heard of that word. It's the compound that causes itching, redness, swelling, hives. That's why people take antihistamines for seasonal allergy issues. Now, again, as we mentioned, this is typically the type of allergy response that's done with allergy testing, scratch testing in a doctor's office today. Now, these histamine reactions don't just cause redness and swelling in the back of the throat. They can affect us systemically. They can affect all these mucous membranes or epithelial tissues. They can affect our skin from an epithelial tissue point of view. An example of that would be a hive. Gastritis in the stomach, heartburn, reflux, indigestion. Some of the medications people are given for those types of conditions are antihistamines. Nausea in the stomach is often a histamine response. That's why diphenhydramine or Gravol or Dramamine helps with nausea. It's an antihistamine. Histamine can cause constipation in the colon. Opioid-induced constipation is a known histamine reaction. Reactive airways with lungs, breathing issues, sensitive airways. Sinus congestion. People will recognize during seasonal allergy season, their sinuses can be affected along with their eyes and their ears and their nose and their throat. Well, histamine is associated with that. And cystitis in the bladder can be a histamine reaction as well. So these types of reactions aren't just eyes, ears, nose, and throat with seasonal allergy issues or with anaphylaxis with a peanut. They can affect all of our epithelial tissues in the body. Now, food sensitivities, these are called delayed hypersensitivity reactions, and delayed is the critical word here. We're going to talk about that shortly. These antibodies are called IgG and IgA. These are not identified on scratch testing. These antibodies typically aren't assessed for most health conditions. Outside of celiac disease would be an example of one. They also produce compounds called cytokines. The inflammation associated with this type of allergy is not typically associated with histamine. It's usually associated with these other compounds we mentioned called cytokines in conjunction with an antibody. So it's a different mechanism from the food allergies. So examples of this, celiac disease is a known classic example of this. Ulcerative colitis, a lot of these mucous membrane inflammatory bowel conditions, there are known to be IgA and IgG antibodies associated with those pathologies. So these two types of inflammatory food reactions, it's the food sensitivities that are the hidden ones and the ones that are so difficult for people to figure out, and quite often they think they don't have any of those. We're going to talk about that next. So to understand these delayed food sensitivities, we're going to talk about vaccines for a minute. Because the antibodies produced to vaccines are IgG and IgA antibodies, the same ones that we're referencing with respect to food sensitivities. So with a vaccine, we get a tiny little dose of this antigen or this vaccine right here. It will go and interact with what are called white blood cells, B cells. There's all kinds of other cells called antigen-presenting cells. That whole interaction is extremely complex and well beyond the scope of this video. Essentially what happens though, it leads to the production of antibodies and cytokines. These are soldiers and arms that the immune system produces to go and attack and kill bugs, bacteria, and viruses. So imagine you get a tetanus shot. You get a tiny little dose of vaccine, the size of the tip of a pen, 0.5 milliliter. Your white blood cells interact with that and the B cells. They produce a millionfold antibody response. And those antibodies to tetanus can stay in there for 8 to 10 years. A tiny little dose, massive response lasts for a long, long time. Well, why that's important to know, you can have the exact same immune response to a food. We can eat a tiny little dose of food. We can produce a massive immune response to it. Those antibodies can take 2 to 4 weeks to get produced. So when you get a vaccine today, the photocopy shop that produces the antibodies will take 2 to 4 weeks for them to reach their peak. If you go on a trip somewhere and you have to have a shot before you go, you have to have the shot 2 to 4 weeks before you travel. So the antibody production takes time. That's a really critical point to keep in mind. Why that's important to know is we can have that exact same immune reaction to a food. That's what we're going to show next. So imagine with an allergy, the immediate hypersensitivity reaction to a food. We would eat the food right here. The antibody would rise very quickly and come down very quickly. So because when we eat that food, the reaction happens so quickly, we can normally figure that type of reaction out. But with a delayed hypersensitivity reaction, the dynamics are a little bit different. We can eat a food right here. The antibody can take up to 2 to 4 weeks to reach its peak like this, and then can fall very slowly over the next several weeks to months. Now the difference is, if we eat a food right here, and we have a symptom here, here, or here, we're not going to correlate that food ingestion to that symptom. We could eat a food today, it could bother us tomorrow, it could bother us 3 days from today, it could bother us 5 or 6 days from today. Now the problem with that is if we eat a food today and it bothers us tomorrow, or the next day or the day after that, we may not figure that out. So what are we going to do? We're going to eat that food repeatedly over and over again. Every day you eat that food, the antibodies compound and build up on top of each other. Now, this can lead to a chronic, ever-present, overlapping inflammation that you'll never correlate back to a food in your diet. So you will have this chronic, low-grade, ebbing and flowing inflammatory state, and you will never think a food could have caused it because there wasn't the cause and effect that happens with the histamine reactions. So you can see how that would be almost impossible to figure out. Even through food journaling, it's almost impossible. Now, back to the histamine reactions. Now, people often say to me with histamine issues, I know I'd have that because it would happen as soon as I eat the food. Well, there's a way that that can actually be hidden from you. If we eat a food here, and it causes a symptom right there from a histamine reactive point of view, and we could eat a food right here from a delayed point of view and have the exact same symptom right there. So the delayed reactions can actually mask and cover up the histamine reactions. If you don't feel well after supper tonight, you don't know it's what you ate at supper tonight, what you ate yesterday, what you ate 3 days ago, 5 days ago, or a week ago. So how we figure this out is we have to identify and get rid of these delayed ones right here, and then it's quite easy to figure out these histamine reactions. So as we get older, often our diets don't change, but it's our barrier that causes the problems here. We can have these immediate and delayed inflammatory food reactions lead to a diminished barrier through these mechanisms we've just talked about. That's depicted right here in this diagram. Another term for this in complementary health circles would be leaky gut. There's little cracks forming in the gut that will allow things to get in that shouldn't get in. Again, that job to keep things out that aren't supposed to be in. Well, right here, that can lead to exposure not just to bugs and bacteria and viruses, but also to food proteins that shouldn't get absorbed through a healthy intestinal lining. Both of those can lead to an immune exposure and inflammation in that tissue, but also an inflammatory immune reaction that goes systemic into the bloodstream. Quite often, this immune exposure will come back and lead, through this leaky gut mechanism, an increased exposure for inflammatory food reactions, either the immediate ones here or the delayed ones. So you can see the feedback loop that's happening here. An inflammatory food reaction can lead to a weakened barrier. That weakened barrier can lead to more inflammatory food reactions. So it magnifies itself, it amplifies itself. So as we talked about a couple slides ago, these IgG and Ig antibodies are the same ones produced to vaccines, but they're also the same ones produced to provide immunity to bugs and bacteria and viruses that we get exposed to. Now, the immune system isn't doing just one job from an infectious point of view with these antibodies. These antibodies, again, can be produced against foods. So this is an ELISA test, an enzyme-linked immunosorbent assay test. I use this quite often with patients to help figure out these delayed inflammatory food profiles for them. The lines you see here are level of the G or A antibody in the bloodstream to the foods depicted in these columns. We won't get into interpreting this test result. This was actually my father's test result. What I'd like you to see, though, is anything above this red line right here is an indication of an abnormal response, meaning a high response to those foods, a high antibody production to those foods. Now, the big difference that we see here is that these antibodies, when a person eats them, they're not just producing those antibody responses once. Every time they eat that food, there's another exposure. It would be like getting a vaccine day after day after day. Well, every time we eat those foods, we get another exposure. We can produce another immune response to that. So we can see what kind of impact that might have on the immune system's ability to produce those against other infectious agents. So quite often we hear people saying, I need to do stuff to boost my immune system. What can I take to boost my immune system? I often say, instead of asking what can we take to boost our immune system, the better question to ask is what can we take away that may be draining or straining our immune system? You can imagine if we took all of these foods away from my father, his immune system would have been much better able to go and fight what it was supposed to fight. Now, my father did have some digestive tract issues, some mucous membrane inflammatory issues, which resolved significantly when we addressed these food issues. So from a chronic infection point of view, addressing the foods would have done two things. It could have improved his barrier in the digestive tract and his lungs and things like that by getting rid of an inflammatory irritant on them. But it could also have boosted his immune system ability to go and produce the antibodies that it would need to fight infections. So imagine we have a bucket here filled with immune resources, white blood cells, T cells, B cells, platelets, cytokines, all these different compounds and components of the immune system we've been talking about. So this bucket has constant strains on it or constant drains on it, either taps or little cracks in the bottom of the bucket. We have chronic bacterial exposure that our immune system keeps at bay so we can go out and about and not worry about them. We have chronic viral exposure. Well, now we've talked about chronic inflammatory food reactions that can also go and impact that immune system. Now, when most people come see me with these immune issues, they want to know what can they take to boost their immune system. So the rationale here is, what can I take to fill that bucket back up again? The big issue with that is, if we have a bunch of holes in the bottom of the bucket, the resources will go out through the bottom. What we have to do is repair the bottom of the bucket. And one of the more effective ways to do that is to eliminate the inflammatory food reactions, and then we can go and support and pour things in on top of that bucket. That way they're going to work a whole lot better. We won't need to do them as much, and they won't have to be as complicated. So the best way to fill up that empty bucket from the top is to make sure the bottom doesn't have holes in it. So when people have these chronic immunological infectious issues, sometimes it's in the lung or the sinus, the urinary tract, sometimes the digestive tract with H. pylori or lower bowel infections. So the question then becomes, why do I have it in this spot? Why doesn't everyone have it in the same spot? Well, one reason for this is, with the delayed antibody reactions that we talked about, the delayed hypersensitivity reactions, the antibodies are what target specific tissues in the body. And celiac disease is a great example of that. Someone eats gluten, which, we'll imagine it's a protein that looks like that red squiggly line here. The immune system, the T cells, B cells, antigen-presenting cells, they produce antibodies which will go out and target anything that has that shape right there. They're little soldiers going out and looking for that little protein. Well, celiac patients will have a protein in the bowel that looks exactly like it right here. So the antibodies designed to attack anything in the body that looks like gluten will attack this protein in the bowel that looks like it. Now, these proteins in the bowel are coded by your genes and DNA, and what your white blood cells here interact with allergically is coded by your genes and DNA. We know celiac disease can actually run down through families. We know other autoimmune diseases can run down through families. This is a good example of this genetic coding for which tissue is going to be targeted by which food antibody. So from a delayed hypersensitivity point of view, these delayed reactions, if someone can have an allergy to gluten, produce an antibody to it, and the antibody cross-reacts with the protein in the bowel that looks like it, why couldn't a different person with different genes and DNA be allergic to a different food protein and have the antibody to that protein cross-react with a different tissue in the body? That's logical, and that makes sense. We're going to be having a video coming up very shortly on that, on autoimmune diseases and food sensitivity, so I'd encourage you to subscribe if you're curious about that. The concept is called molecular mimicry, and it's actually very simple. You eat a molecule, a protein structure that you're allergic to or sensitive to, you produce an antibody to it, and you have a protein in your body that looks like it. So you get a cross-reaction from one to the other. It's a case of mistaken identity. So now people will start to think, well, I need to do an anti-inflammatory diet. I need a low histamine diet, and I'm going to find the best anti-inflammatory diet on the internet. There are some significant troubles with that. The best ideal anti-inflammatory diet for each of us is unique to each of us and each of us alone. These inflammatory food reactions are immunological reactions. They involve a white blood cell with receptors on it. The receptors are like little arms with feelers on the end. And these little feelers bounce into things in your body, and they touch things, and they determine what's allowed or not allowed in your body by how they feel. It's these little receptors right here that we're talking about. They're coded to bind to very specific shapes right here. So it's our genes and DNA that determine the shape of the white blood cell receptor. Imagine it like a lock and key. Well, the receptor is the lock. The antigen or the allergic protein would be the key that goes into the lock. You need a very specific protein structure to turn on each lock. Now, what those receptors are going to target, the shape of the lock, is determined by your genes and DNA. So your inflammatory food reactions, what your white blood cells or receptors are going to determine is bad for you, it's determined by your genes and DNA. It's not determined by an anti-inflammatory diet program off the internet. It's not determined by your favorite health guru or a YouTube video. It's specific to you. That's what we have to figure out. From a delayed hypersensitivity point of view, there's actually research to support this. There's a good one here on ulcerative colitis. You can look at the citation there and investigate if you want. There was two groups of people put on two different diets. One was a generic program. The other was put on a diet specific to their IgG food reactions that was determined through ELISA testing. So the group that was put on the diet specific to their IgG antibody responses showed significant improvements with respect to their ulcerative colitis compared to the group that was put on the generic diet. Now, I also have a video just specifically on this unique inflammatory food profile and how it's different for everyone. It's called The Trouble with All Anti-Inflammatory Diets. There's going to be a link in the video description below. It will show you very clear examples of how what are perceived as healthy foods can cause problems, and other times people eating what they thought were unhealthy foods and they weren't causing problems. It'll show you test examples and case studies showing this unique variability with respect to inflammatory food reactions. I'd encourage you to watch that. The link's in the description below. So now more on why it tends to affect different people in different places. The surface vulnerability, prior injury, trauma, surgery, those sorts of things can impact how the integrity is going to be in those mucous membranes or those epithelial tissues. Environmental pressures. A smoker is going to have more pressure and irritation in his lungs. Someone who drinks a lot of alcohol is going to have more of this pressure in their stomach and digestive tract. Environmental issues. People in toxic environments with air environments, again, they will have more exposure in the mucous membranes of the back of the throat, the sinuses, and the lungs. So these factors do affect surface vulnerability with respect to chronic infections. Then we add molecular mimicry to it, the concept of this allergy to a food protein and the antibody cross-reacts with the tissue. Our individual inflammatory food profiles are unique, so there's not one food that always causes irritation of the sinuses and leads to sinus infection, or another food that leads to irritation of the bladder and leads to bladder infections. It's different for everyone. You could have 10 people with the same food reaction, and it can affect them in 10 different parts of the body. Tied to the molecular mimicry, it's not just the individuality of the food reactions, it's also the individuality of the protein structures that are going to interact with that immune response. So you can see the possibilities there are infinite or almost endless. And this will lead to the surface affected. So if the combination of surface vulnerability and molecular mimicry affects the sinuses, it's going to lead to chronic sinus issues, congestion, postnasal drip, possibly infections. In the lungs, in the respiratory tract, it can lead to worsening asthma, but also a weakened barrier there to particulate in the air, but also to viral infections that we may eat, breathe, or drink. If the surface affected is in the digestive tract, that's going to lead to sort of low-grade inflammatory issues in the stomach. It can be reflux indigestion or GERD problems. The colon, it could be constipation problems. The surface affected in the urinary tract, this can lead to symptoms of urinary frequency, urinary irritation, and sometimes infections. Nighttime frequency, things like that. Now, a histamine reaction in the bladder can actually cause symptoms that can mimic a urinary tract infection. Sometimes people with these recurrent bladder infections or recurrent cystitis, quite often they will test negative on tests, but they will be treated for an infection anyway. That can be a really good indication of an underlying primary inflammatory process that then is allowing an exposure to take root. It's almost like the infection is secondary to the primary inflammation. In the reproductive tract, it can lead to pH problems there, which can lead to recurrent yeast infections and things like that. Now, with everything we've talked about, it has to be said very clearly, if you have an infection, it needs to be treated. I'm not suggesting food issues will treat these infections. What we're talking about here is the pattern that happens. If you get an infection, you have to treat the infection. We just want to see if we can decrease the susceptibility to getting the infections. That's what the goal of this video is about. A closer look. Imagine this is a cross-section of the vaginal lining. We have the epithelial layer right here, the mucous lining right there, that blue little line. A healthy vaginal pH, we're going to have a good ratio of bacteria to yeast, sort of depicted by the blue and the green microbes here. Now, if we inflame that epithelial lining, the barrier becomes weak and the tissue becomes more acidic. An acidic environment is more favorable to a yeast growth than a bacterial growth. Yeast are often spore-based microorganisms. They have a spore casing wrapped around them. It's like a protective barrier to help them live in harsh environments better. Bacteria are single-cell walled organisms. They don't live in those acidic environments as well. So if we have an inflamed, distressed epithelium and the pH is somewhat lower than it should be, we're going to have a slight imbalance of yeast to bacteria. It's almost like you don't have a yeast infection, but you're right on the cusp of having an infection. It's like it creates a yeast susceptibility in you. It doesn't take much of an intrusion or an issue to go and bloom that yeast and cause a problem. A good example here would be sex. If a woman has sex and semen is introduced, which is fructose, well, fructose is fruit sugar. What does fructose do to a yeast in a warm, wet environment? It's going to allow that to bloom. So in that scenario, if a woman says, every time I have sex, I get a yeast infection, they blame her on the sex. Well, there's lots of women who have lots of sex and they don't get yeast infections. So the women with that issue have this underlying inflammatory pH imbalance that's going on, and sex tends to be the straw that breaks the camel's back. If we can address that underlying epithelium, address the inflammation, and correct the pH, then we should be able to reduce that susceptibility. We have a healthy epithelial layer right here with a good barrier. This can repel a lot of the microorganisms and stuff that are going to come in contact with what's called the urothelium, not in the urinary tract, not the epithelium. It's the same basic tissue structure and function though. Now, if we inflame that and irritate that urothelium, you can see it right here, and we get those same exposures, it's almost like an open door for infection. These microorganisms can adhere to that tissue now. They can start to colonize and grow. A problem we have when that happens is that once we get that infection, the infection can go and cause more irritation in the tissue. So it starts to feed itself. A weakened barrier, a distressed barrier can lead to an infection. The infection can go and weaken and distress the barrier more. Again, that negative feedback loop we talked about. A closer look at the sinus and lung. This would be an sinus example. Some of the technical structures are slightly different, but the basic concept still applies. We have the epithelial layer right here. A healthy epithelial barrier will be able to repel those microorganisms we talked about. We'll be able to flush them out. We have cilia in the epithelial layer there. These are structures that will sort of wave and be able to move stuff through those tissues. So when we have to move stuff up out of the lung or move stuff out of the sinus, the cilia allow us to do that. Now, if we inflame that epithelial layer, the mucus becomes sticky and goopy. It becomes less able to do those jobs. It leads to an open door for infection or adherence for those microbes in that tissue. And the same concept applies. Once we get that infection right here, it can spin back around and irritate the tissue even more. So we can get into that feedback loop there as well. So you can see a lot of the same concepts are applying regardless of which epithelial or urothelial tissue we're talking about. This slide just shows the loop again that we've been talking about. We get an inflammatory reaction right here, irritates the tissue. We get exposure, the tissue becomes irritated. So then we get treatment for that infection and we get resolution. But if we don't get rid of this problem over here, the whole cycle is just going to keep repeating itself. So the treatment is necessary, but we have to figure out why the pattern is repeating itself, why this loop is happening. And quite often it's this inflammatory picture over here that can be the initiating step in the whole process. So this is one of the reasons why the treatment-only approach tends to fail long-term with chronic infections. We have to treat the infection, but if the barrier remains compromised, the susceptibility will remain. So we have to address that barrier. The treatment worked for the infection. It's just the surface or the barrier didn't change with the treatment. So we have to ask the right question. Instead of focusing on just how do we keep eliminating this microorganism, we have to ask why is the pattern happening and what's allowing that organism to get in and take root. So how do we identify and change that pattern? We have to identify all the unique and individual inflammatory food reactions along with treating that initial infection or the infection that's presenting to us. This isn't based off generic anti-inflammatory diets. It's based off your specific profile that we have to figure out. Step 2, we have to remove those foods, and we have to do it long enough for these delayed antibodies to get out of the system. With a delayed antibody response to a food, the antibodies sometimes can take 2 to 3 weeks before they even start to fall. So we have to be realistic with the time frame for the elimination diet. We also have to do it strictly enough. It's not a case of cutting these foods back, it's a case of cutting them out. This tiny little dose can produce an immune response that can last for weeks to months. So if you have a tiny little dose and you say, well, I'll cut it back mostly, but a little bit won't hurt me. That's like saying to a kid with a peanut allergy, don't eat a lot of peanuts, but just have a couple every now and then. It doesn't work that way. And the next step is then we can go and do the repair work, repair the tissues, do the gut flora balancing, start to repair that mucous membrane. There's some really simple basic concepts here, L-glutamine pattern, some of the herbal demulcents, probiotics. But until we get rid of what's causing that initial damage, that initial irritation, you're trying to put paint back on a wall while someone's on the other side poking holes in the wall. We have to get rid of what's causing the damage before we can repair the damage. And these steps need to be done. They need to be done in order. If you skip a step, the pattern's going to continue. So the order that we address these things is really, really critical. So does this apply to you? If you've had repeated infections, the same type, they get treated, they resolve, but they tend to come back, this could apply to you. This is an important one. If you have symptoms that feel like an infection, but they test negative, and eventually down the road they will test positive, that's a really good marker that there's an underlying inflammation causing the initial irritation, and the infection follows it. So that could apply to you. And quite often, it's not just going to be in one tissue. You may have chronic bladder infections, but you've also got a little bit of sinus congestion, a little bit of heartburn. Quite often, it's going to affect multiple tissues. So if you have a chronic recurrent infection, and there's other mucous membrane-based issues as well, quite often this can be part of your picture. In short, if these infections keep coming back, there's something that's allowing them to get in the door. We have to figure out what that is, and then we have to close and lock the door. One last disclaimer here is that if you have an active infection, you have to treat that infection. That's a critical part of this. The infection, again, can come back and irritate the tissue, so you can do the food work. But if there's an active infection there, that's going to stall the progress you're going to make with the food work. So you have to treat the infection first. If we do that, the hard food work, we're going to get much greater responses with it. So what does this food work involve? What's the investigation involve? It's not just a different version of something you've already tried. But quite often when people come to see me, they've already done an elimination diet. They say, I tried dieting, it didn't work, we have to do something different. And what I say to them is, you did an elimination diet, you didn't do your elimination diet. You did a program that was based off generic population averages that may have helped some people, but they didn't help everybody. There's a really good chance that that elimination diet didn't fit your immune profile. So we have to do your diet. It's a technically different method. We start by identifying the delayed reactions and then following that by identifying the immediate histamine ones that could be lingering. Remember, the histamine reactions can be covered up by the delayed reactions. We have to do these diets to allow for the differences in timing. The histamine reactions can happen quickly. The delayed reactions can happen in a delayed, long-lasting manner. So we have to take all that into account when constructing the elimination diet. And we have to account for each person's unique and individualized inflammatory food profile. That is critical. That's the big missing step for most people when they do these inflammatory diet programs. Then once these foods are eliminated and people are feeling better, we have to do the challenge process in a very structured way. If you avoid a bunch of foods, you feel better, and then you put them all back in randomly, you're going to be right back at square one again. You have to challenge the foods, taking into account the possible delay in the reaction to each food you put back in, and you have to know what to look for. If we do the challenge process the right way, this is what allows people to avoid unnecessary food restrictions. If you go to a program that says take out 10 foods and you feel better, it doesn't mean all 10 of those foods were causing your problems. It may have been 1 or 2 or 3. So if we go through the challenge process the right way, you might have a feel-good diet that involves 2 or 3 foods as opposed to 10 foods. That's going to be much more manageable and feasible for you to do long term. So we need to construct these protocols for long-term feasibility versus just short-term gain and then a reoccurrence of the problem. I have an online program, again, link will be in the description, for people that don't have a practitioner, a functional medicine practitioner to work through these concepts with. There's more information on my website and a link below for that. So reoccurring infections. Why does the same infection keep coming back? The exposure is only part of the problem. We have to understand why the exposure gets in. What's the open door? That's the key to figuring this stuff out. So where to start? I have a free guide. Again, the QR code is there. The link is in the description. That starts with understanding these different types of food reactions. That can explain a lot of why people haven't been able to figure these food issues out on their own. It's also a summary of the first module in the course. So it'll give you an indication of the things we talk about and the program that we have developed for that. All of the concepts we've talked about here are also in a book. There's a link on my website and down below called Recurrent Infections Revealed. Inflammation first, the infections follow. It talks about the exact same concept we talked about here in more depth, and it provides research citations and backup for the concept that we talked about. So if you'd like to learn more about this in more detail, I'd encourage you to go there as well. So the short of this, one of the key aspects to chronic infections is why is the infection getting in? That's this inflamed mucosal epithelial or urothelial layer that we're talking about. And food can definitely have an impact on the integrity of that tissue. We can't make people younger again. We can't make a menopausal woman not menopausal anymore. So there are factors that we can't address from a mucosal epithelial integrity point of view, but food is one that we can. Thanks, and we'll see you in the next video.